Right, let's get straight into it. We're going to do a deep dive, a critical appraisal of the VOYAGER PAD trial. This is a landmark study, and we're going to break it down to the standard you'd expect in an FRCS Viva, focusing on what really matters. So, here's our plan of attack. We'll frame the question using PICO, then we'll scrutinize the internal validity. How well was this trial actually done? After that, we'll get into the weeds with the statistics, look at the key results from an examiner's point of view, and then talk about external validity and limitations. Finally, the big one, the verdict on how this changes our practice. Okay, first things first, the PICO. This is our foundation for understanding exactly what the investigators set out to answer. So, who are we talking about here? The population was patients over 50 with symptomatic PAD, all of them studied within 10 days of a successful lower limb revascularization. This is a really high-risk group at a particularly vulnerable time. And notice, they included both claudicants and patients with chronic limb-threatening ischemia. That's a key point we'll come back to.
What was the intervention? Well, we're looking at dual pathway inhibition, specifically the so-called vascular dose of rivaroxaban. That's 2.5 milligrams twice a day, on top of standard aspirin therapy. Smartly, they also allowed for short-term clopidogrel at the investigator's discretion, which, really reflects real-world practice.
And the comparison? Simple. Aspirin alone with a matching placebo. This was the standard of care at the time, so it gives us a really clean, appropriate baseline to judge the intervention against. Now, the outcomes. This is critical. The primary efficacy outcome was a really robust 5-point composite of major adverse cardiovascular and limb events. So that's acute limb ischemia, major amputation, MI, stroke, or CV death. On the safety side, the principal outcome was TIMI major bleeding, and the key secondary safety outcome was ISTH major bleeding. This distinction is absolutely crucial for how we interpret the results. All right, let's move on. Internal validity. We're going to dissect the methodology to really understand just how robust these findings are. From a methodological standpoint, VOYAGER PAD is solid. It's a large, international, double-blind, randomized controlled trial. That's our gold standard. They used an intention-to-treat analysis, which is exactly what you want to see to preserve the randomization. They also stratified by revascularization type and clopidogrel use, making sure those key potential confounders were balanced. And crucially, an independent, blinded committee adjudicated all the key events, which is a massive plus for minimizing bias. Now, here's a classic critical appraisal point. The fact that they included both claudicants and CLTI patients, well, it's a bit of a double-edged sword, isn't it? On one hand, it hugely improves the trial's generalizability. It makes it look a lot more like our actual practice. But on the other hand, you're introducing a ton of heterogeneity in baseline risk, which can create statistical noise and make it harder to see a clear signal. Let's talk about treatment discontinuation. The rate was pretty high, about 32% in both groups. Now, because it was balanced, it's unlikely to have introduced any major bias. But, and this is the key insight for an intention-to-treat analysis, a high discontinuation rate like this will almost certainly attenuate or underestimate the true treatment effect. The real effect is probably even stronger than what they found. Okay, let's crunch some numbers. A solid grasp of the stats here is fundamental to interpreting the trial's conclusions correctly. The statistical approach was spot on. They used Kaplan-Meier estimates for their survival curves and Cox proportional hazards modeling to figure out the hazard ratios. This is standard, robust methodology for an event-driven trial like this. No issues there. So, the big headline number, a hazard ratio of 0.85 for the primary outcome. That translates to a 15% relative risk reduction in that composite endpoint for the rivaroxaban group. So what does that actually mean? Well, if we look at the 95% confidence interval, it runs from 0.76 to 0.96. The key thing here is that it does not cross 1. So the result is statistically significant, no question. But more than that, the event rates here were high, nearly 20% in the placebo group. This means the absolute risk reduction of 2.6% gives a number needed to treat that is actually very clinically meaningful. Right, we need to be crystal clear on this difference between TIMI and ISTH major bleeding. They are not the same thing. Think of TIMI as having a much higher threshold. It's designed to pick up the most severe, life-threatening bleeds. ISTH, on the other hand, is far more sensitive with a lower threshold. The fact that they chose the less sensitive definition as the primary safety endpoint is a really important discussion point when you're weighing up the overall risk-benefit profile. So, we've picked apart the methods. Let's synthesize the results now with the kind of emphasis you'd need in a Viva. What are the absolute must-know take-home messages? First, the primary composite outcome was met, a clear, statistically significant win for rivaroxaban. But, and this is the crucial part, what drove that benefit? Well, it was overwhelmingly driven by a massive reduction in limb-specific events, especially acute limb ischemia, which was cut by a third. It's absolutely essential to state that there was no reduction in cardiovascular mortality. Now for the other side of the coin, safety. The primary safety endpoint, that high-threshold TIMI major bleeding, was not significantly increased. However, when you look at the more sensitive ISTH definition, major bleeding was significantly higher. But here's the really reassuring part. While there was more major bleeding, it did not translate into an excess of the things we fear most, fatal bleeds or intracranial hemorrhage. Okay, so we've got the results, but how does this apply to our actual clinics? Let's talk about external validity and the trial's limitations. And the short answer is yes, the external validity here is high. Very high. Why? Because this trial population, it looks just like the patients we see on our wards and in our clinics every single day. The pragmatic inclusion of everyone from claudicants to CLTI patients, and the fact that it applies to both open surgery and endo procedures, means these findings are directly and widely applicable to what we do. Of course, in any good appraisal, you have to address the elephant in the room. What about the industry funding? How do we interpret the results knowing the drug's manufacturer paid for the trial? And it's a fair question, but you have to look at the trial's governance. In this case, the potential for bias was really robustly mitigated. You had an independent academic research organization providing oversight, the statistical analysis was done independently, and, as we've already said, all clinical events were judged by a blinded independent committee. Those checks and balances give us strong confidence in the integrity of the results. So let's bring it all home. The final synthesis. What's the bottom line? How does Voyager PAD actually change our clinical management? To put it bluntly, Voyager PAD is a practice-changing trial. Full stop. The findings are clear and the implications for how we manage these patients are profound. The clear, actionable conclusion from this tick is that dual pathway inhibition with low-dose rivaroxaban plus aspirin should now be considered the new standard of care for our patients after lower limb revascularization, provided, of course, they aren't at a prohibitive risk of bleeding. Patient selection, as always, is absolutely key. And, this is bigger than just one drug. This represents a real paradigm shift in how we think. For the first time, we have a medical therapy that is proven to significantly reduce major adverse limb events. It moves our focus beyond just preventing MIs and strokes to making limb protection a primary therapeutic goal in its own right. So to conclude, this is without a doubt one of the most important, well-conducted PAD trials of the last decade. It answers a critical clinical question with robust methodology and gives us a clear path forward for improving our patients' outcomes. From an examination perspective, this is a clear pass.